So let me try and summarise a little bit of what I've heard, and probably inadequately. First of all, Dr. Sabelas reminded us of the need for cultural sensitivity in our Adventist health work. Nevertheless, we're all part of the human race and there's a lot of commonality, but Adventist healing will need to take into account the cultural context. And I'm sure in Europe you're more familiar with this than we are even in the United States. Dr. Landless emphasized the difference between cure and healing, and that the biblical theme is actually restoration with, I think, a prominent component of peace. Nevertheless, our behavior should always be to the glory of God. Our bodies are important, and God cares for the whole person. That was the theme that came through time and again, wasn't it? With a wider view of health being body, mind, and spirit. Dr. Harding talked about the tradition of Adventist healing, which is kind of a wonderful tradition actually when you go back and summarize it, and that it was rooted in creation. And the point that I got there is that we understand the perfect model as exemplified in Christ. The importance of spiritual health, he mentioned, and the relationship with God to emotional health. Again, whole person care, and that physical health is only part of the picture and not enough. Dr. Handysides made a big point of how shame is such a negative emotion, and that we don't need to remind people of that when we become aware of their physical inadequacies. And all the relationships of life need to be healed, he said. And that the cure was not really the result of our doing as physicians and nurses and health professionals, but was really the way that God created our body and how it could restore itself. We just took away the impediments to God's healing. And he also mentioned the theocentricity of our health message and how it's intimately related to our spiritual ideas. Well, a few comments and then some questions. And I think we'll start with the panel and open it to the floor. It was suggested to me, we'll see how it goes, but in the latter part of the discussion. I was intrigued actually early on with Elder Cooper's presentation that Adventist healing must focus on community. I guess I'm generating just too much electricity up here, aren't I? And that we must focus on the community and not just on the hospital, which has become our way of doing things to some extent. It has always seemed to me that one pillar of religious life is also community. If we are good citizens of the community here, and if we have a relationship to our Lord, then we will be invited to join the heavenly community. The way we relate to each other, I think, here is very important. And thus, Adventist health being part of a community, and I think religion having a strong community focus tends to bring these two things together. Well, let me pose a question. So Adventists are people of the Ten Commandments, is that right? It's kind of right, isn't it? Certainly historically. Yet we can avoid killing and lying and becoming adulterers and stealing and never lift a finger to help anyone else. So is that a challenge for us, do you think? We can be good people, good Christians, and yet have not a lot of concern for our neighbours. The commandments, at least superficially, don't focus on healing. And I'll be interested if any of the panel have some reflections on whether our Adventist traditions can be a problem in that regard.
I think that basically right in the tone that was set by the worship and devotion this morning, the element which is intrinsic and must be present is that of service. Otherwise we become navel-gazing, We have the fat cat syndrome, where we say, what is the church doing for us? Whereas the question, when Jesus established his church, and he turned to Peter and he said, upon this rock, meaning himself, I will build my church. It was a church in the community. It was a church to serve. It was a church to reach out with no strings attached. So yes, I agree with you that our traditions can lead us to become very centered on the fact that we live 7 or 9 years longer, that we have less diseases, that we have this. But what are we doing to make that a way of life attractive, without shame, and with no strings attached to others? And that's where service comes in.
Right, the importance of service. I think Dr. Cambelis.
Yes, later on today, one of the workshops I'm having with Dr. Handyside, we're going to speak a little bit more about that. And I do not believe that our traditions are a hindrance. But depending on how we view it, depending on how we talk to our children, if we portray a God that is a very severe God, that is waiting to punish you, that will increase the stresses on the people, and that can be detrimental if you view God that way.
Yeah.
Traditionally, Adventists, and I'm going back now perhaps to my grandfather, because I'm a third generation Adventist. I know that they loved argument. They loved a message. They loved to be able to defeat somebody else in argument and convince them out of the Bible that they were right. That mentality seldom experiences grace the way that it should. When I first came to the General Conference Health Ministries Department, I gave every member of the department a little book by Philip Yancey called What's So Amazing About Grace. Because if we are going to have a ministry that is meaningful to those to whom we would minister, it must be filled with grace. If it's a ministry of actions, of prohibitions, of admonitions, of ought tos, shoulds, musts, it misses the grace of Jesus Christ. And as I listen to the current talk and debate that goes on at the General Conference, when all the world leaders gather together, we're talking about revival and reformation, and we are talking about the latter rain. It was very enlightening to me to read Ellen White say that the latter rain will be an outpouring of grace. I just hope that we can get that concept, see the vision, and become more gracious.
Yeah, thank you. Very nice comment. So, I mean, it's always struck me interesting that the Ten Commandments, at least from 5 onwards, are framed in a negative sense. Have you ever tried to turn them over and say, not that I should steal, but what I should give my neighbour and help him? Not that I should not kill someone, but that I should enhance their life. And it's quite interesting to go down the list and try and do that, and it puts a different perspective on things in that way. Well, let's move on. Thank you. So, talking about different cultures, what about the subcultures within our Western church? And this was kind of alluded to a little bit. I think, Fred, you made some allusion to this. For instance, some in our midst deny the validity of modern medicine and shun medicines even when they need them. And I'm a physician. I do prescribe medicines. And it's interesting that in the Adventist Health Study, our vegetarians, and I'm a vegetarian, and especially our strict vegetarians, do not tend to participate in recommended preventive care for cancer. Things like an occasional colonoscopy and prostate screening, pap smears, mammography. They participate only about a third as often as our non-vegetarian, all Adventists. Now, isn't that interesting? So how do we relate to very different opinions about traditional medical care? And sometimes it comes back to the nature of evidence. You talk to different people. I have people that sit in my office, and they have very different views of what is good evidence and what is not good evidence. And so, even though we have different cultures in different countries, we have to face the reality that we have very different views of things within our own churches in North America, and I'm even sure here within one country in Europe. So I don't know if any of you, I'm sure most of you have thought about some of these things, and somehow they need to be addressed. I see the microphone coming up.
Yes, in my research, titled The Correlation Between Spirituality and Healing in Cardiovascular Patients that present with hypertension for my doctoral degree, I interviewed 100 persons, and I asked them, we did a little bit of testing on their blood pressure, et cetera, et cetera. All of them were heart patients. I discovered that about a small sample, only four of them, had very high blood pressure and very high religiosity index. When I began asking them about their practices, I discovered that all of them have been with their blood pressure medication for at least a week to week and a half, because they felt that God was going to take care of them. So I know that further studies needed to look at the correlation between spirituality and compliance with the medical plan, that I venture to say that is a little high, just what you said. It is a challenge with people that are highly religious, because they feel that God will take care of them and they do not need to follow the medical plan. It was interesting that as I was doing the research, I spoke with one of my medical residents, and he had a patient that came in with the same problem. And he asked her, "Are you taking medication?" She says, "No, God will take care of me." And then he asked, "Do you think that God has anything to do with me being able to become a physician?" She said, "Of course." "What about, do you think that God works with me when I try to indicate to you what kind of medication you should take?" She said, "Well, yes, of course." And then he went a little farther, saying, "Well, if you do not follow my advice, it's like if you are disobeying God, because God is working through me." But that shows that, yes, there is a problem with highly spiritual people, that they try to disregard the medical plan.
It's a very interesting point that I think we need to, especially as the choir, those who, most of us here are very passionate and believe in the health message, and we seek to practice it. As a dietitian, I have worked with people who I think are so worried about every little thing they do with diet that it produces hypertension and stress in themselves, let alone those around them sometimes, because of their attitudes. And we can all be pursuing the skinny body, the healthy body, but we can be doing it for the wrong reason and with the wrong attitude. And we need to make sure that it's, as Alan has just said, that we're approaching it as a gift of God that we incorporate by His grace and our choices. And then we can relax and not worry. And I don't want to be misunderstood, Gary, and I'm a vegetarian and have been all my life. I sometimes ask people, if you have one hamburger in your lifetime, is it going to cause you heart disease? And I think we all know what that answer is. But there are some people that worry that small, infrequent transgressions are causing the problems that they're experiencing. And it may be more of the psychological or the emotional problems than it is actually a relationship, a real relationship with those occasional things. By God's grace, God gives me grace to more and more and each day live more closely to the way He wants me to live, but He doesn't want me to worry unduly.
As I look at Adventists, I think there's a danger that maybe a small proportion of us become obsessed with our diets. And I heard a term that actually my son, who's here with us somewhere today, he told me about this name of orthorexia. So I looked up what orthorexia was all about. Ortho means correct or right, and orthorexia is eating right. And he said that about 4 to 5% of the population is obsessed with eating right. And I think we have a lot of those in the Seventh-day Adventist Church. I think that what we need to do is we need to think of healing and cure and bring a little more faith into our cure and a little more science into the healing. And that way we will achieve balance.
Yes, I mean, I can relate to this as well. I've had people in my office who were getting red in the face telling me how one should never let any processed soy product pass one's lips, that it was evil food, and they were quoting scripture and Ellen White, and probably my blood pressure was going up a little bit as well, being a scientist somewhat and trying to relate to this. So I quite agree. I think these things are unhelpful, and, you know, frankly, the evidence is that the occasional meat, for instance, just from a scientific point of view, is unlikely to cause any harm. And so it depends exactly on what basis you are undertaking your health reform. And it may be that you are treating your body well and so forth for reasons far and above heart disease and cancer and so forth, and that's different. But I think this, what was it, orthorexia you talked about? I think that's a very interesting concept. Fred.
You know, this takes a unfortunate turn sometimes in people's lives. To illustrate that, we have a very dear friend. She's passed away now, but probably about 15 years ago, she was in her late 70s and diagnosed with breast cancer. She asked us to come and visit her. We'd known her for many years. We ate in her home many times. She was a very conscientious person in all that she did. But as we sat in her home that evening and she told us about the diagnosis, she turned to me and looked me in the eye and she said, "Do you think that I have breast cancer because once in a long while I enjoyed a little bit of ice cream?" She was searching for a reason. And I think as we are health reformers and health educators, we need to be careful with the way we present these things. Because there are those who care little about the choices they make, and they seem to live a long time sometimes.
Yeah, so the element of shame. Peter, you had a comment.
I think there's a tremendous difficulty in reaching the balance of understanding. You brought up the term evidence-based. What do we take as evidence-based? And you mentioned this was a general conference morning, so let's go to the general conference working policy, which says that we look at for our health practices to the Bible, the writings of Ellen White, and evidence-based peer-reviewed literature. Now, as we do that, I think we need to also look at the fact that Ellen White writes very clearly that the Bible and science are not at loggerheads with each other. They are in agreement. She also states, and this is one of the statements that really is of great encouragement to me, that one of the sciences, the science we should teach our children earliest is not of astronomy or physics, it's physiology. If we were to rightfully understand physiology, those who are very keen on certain aspects of diet and those who really don't care about diet would come to a much more meaningful understanding of the balance in the middle of the road. We do have instruction, we have got very, very sound principles on which we can work. And so the two are not disparate, or the three: the Bible, the pen of inspiration, and evidence-based medicine. And I think that we can take those and apply them and reach a wonderful balance. And this is one of the huge privileges we have. And I think that has been emphasized in the issue of healing versus cure, and the ultimate total healing of the being, despite often the lack of cure.
All right, well, let's move on a little bit. And I've got a number of questions here. We won't get through them all, I suspect. With a focus on community, which I think is a little bit new in a way, at least in where I grew up in the South Pacific, and I think in the United States, our healthcare emphasis has often been in church halls, where we've had cooking schools and stop smoking clinics and so forth. How about the Adventist involvement in the community and the use of mass media? And of course, we're doing more and more of that now with Hope Channel and many others, which is good to see. But even with channels that are, for instance, just wide community channels. And how about, I guess, my specific question, how about getting involved in the formulation of policy? It's something that we talk about a little bit at the School of Public Health, but it's kind of a new endeavour. But I've been very impressed in the United States over the last 10 to 15 years how policies have really made a huge difference in combination with other things. To say, for instance, cessation of smoking in our communities, where I think we're somewhat ahead of you here in Europe, actually, and perhaps in part for those reasons. So we traditionally, I think, have been uncomfortable with politics and getting involved in community organisations with, non-Adventists, for instance. Any thoughts on that?
I think that I have a certain hesitancy to become involved in party politics. But when it's a matter of influencing, say, the public health, which I always view as the health of the herd, because it's how do you look after your herd? I think we as Adventists have a key role to play. The World Health Organization has recognized that faith-based communities are providing in developing countries perhaps 40% of the health care. And when we first went to the World Health Organization, Dr. Landless and I, we told them that we had relationships with the Adventist Church. They said, sorry, very politely, they said, sorry, we can't work with you. About 3 or 4 years later, owing to a change in their outlook and recognizing the role for faith-based organizations, they welcomed us, and that's what led to the Geneva Conference in 2009, and which we hope to repeat in 2014. Next year, we hope to re-emphasize those relationships. We, as an organization, the Seventh-day Adventist Church, have been pioneers in lifestyle that ameliorates the non-communicable diseases. I would hate that now, as the world is waking up to this message, we as a church would back off from it. It just seems so strange to me. And I hope that we become involved with any kind of organization, community organization, government organization, international organization, such as ICP, the International Commission for the Prevention of Alcoholism and Drug Dependency, that we relate through and with these agencies. This is not ecumenicism. Some people are afraid that this represents an ecumenical movement. This is not an ecumenical movement. This is a movement of influence. And I think the Seventh-day Adventist Church is realizing there is a role for a positive influence in this world today.
Thank you. Any other comments?
It is, I agree with you, Dr. Handyside, and it is always a challenge. Because if you are not pushing an agenda, but if you are trying to influence a public policy that is sponsored by a particular party in the country where you reside, then sometimes you get identified with that party. But we should, regardless of what the consequences, we should be an active participant in public policy. When we look at the Lord Jesus, when he tried to influence maybe not public policy, but some customs that were wrong, by driving away the demons of the demon possessed into the swine that was the main source of food for the people, he got into trouble. So I can imagine that in different countries, as we advocate for healthy living, going away from drugs, that can get us into interesting situations, but nevertheless, we need to be vocal in influencing healthy and healthful lifestyles. Loma Linda has been invited to the White House to work on that, and as we begin to highlight our position in healthful living, I imagine countries around the world, governments, will also open the doors for us to speak on behalf of the health message.
All right. Well, perhaps one more question, and then we'll open it up to the floor and in a few minutes. Peter, you gave some really touching stories of your work with patients, end-of-life care kind of situations, and I'm a cardiologist, so I meet that in different ways. You're a cardiologist also, but that was not the example you gave. People with severe congestive heart failure or people who have had cardiac arrests and so forth. And you're quite right. I mean, I typically will have an intensive care unit, perhaps 20, 25 critically ill patients, a team of residents and so forth. We don't really have a lot of time, apart from to get the medical history right and pat the patient on the shoulder and say some nice words to him, to really sit down with the patient, which is so valuable. And of course, not everyone has that gift, probably in the way that you and others do. But we have a palliative care group, subspecialists at Loma Linda University Medical Centre. And I guess a question I had, is that something which is fairly consistently represented at our hospitals? Because it seems to me that along the lines that you were mentioning, that the kind of skills there are really very important and something that we haven't emphasised a lot, to my knowledge, in our Adventist philosophy of health.
I think I'm going to ask Mario to talk to the hospital component because he works very strongly in that area. But I would like to emphasize from the point of view of healthcare professionals that the surveys are showing that patients would like their caregivers to be more comfortable with the spirituality of their patients. They would like their physicians to be willing to offer to pray with them. On the other hand, and that goes up into percentages that reach 83, 87%. And then you get the converse of that same number of physicians and caregivers who would be uncomfortable to do that with their patients because they are not comfortable with their own spirituality or their ability to give that kind of care. The palliative care that you talk about, I think, is very important. And I think that to have that kind of focused care within a hospital setting would be invaluable because of what you're saying, the lack of time. One is pressed by time, by DRGs, by having to get patients out, by having to get, and shift work brings that about as well. However, I think that if we go back to our devotional this morning, where Jesus was and is our pattern man. Sometimes in our way of approaching healthcare, we go so much to the pre-packaged, the palliative care. The cardiologist evaluates the ejection fraction. The surgeon does the surgery. The anesthesiologist determines whether or not this is a reasonable risk to do. We lose touch of the whole patient. And I think that we, as health professionals, as Seventh-day Adventist health professionals, nurses, physical therapists, occupational therapists, physicians, should, by God's grace, have an openness to address that need that the patient may have. And sometimes that may just be placing a hand on the patient. It may just be putting an arm on their shoulder. It may just be looking them in the eye. It comes from understanding it's not the liver in bed 3, the fistula in bed 10, the broken leg in bed 7. It is the person that has that. And that's where I think, going back to one of your earlier questions, where our tradition sometimes gets in our way. We're running hospitals, no mission, no margin, no mission. We've got to get it and keep it going. We lose sight of those issues which can make a huge difference.
I think that your question focuses on something that's very, very prevalent in Adventism, and that is that we don't believe in some types of medications. And Mrs. White spoke quite forthrightly about some medications, and she named them: opiates, tobacco, alcohol, heavy metals, mercury, antimony, some of those things, which are poisons. And I believe 100% she was right in condemning those medications. But she was not condemning medications for eternity, because there are medications on the tree of life that are for the healing of the nations. And so she obviously was referring in context. The problem is, in palliative care, we have reached a situation where everyone has acknowledged that we know of nothing more that we can do for this patient. And if that patient medically cannot be helped in any way and is in the process of dying, but is in pain and is going to leave this planet and go, well, leave life, is going to leave life in agony and despair, would it not be better to administer something that would remove the pain? That's what palliative care is all about. Would the removal of the pain permit, maybe not the most clear of thinking, but at least a degree of thinking that is far advanced over that when you're distorted by pain? And I think that's a question each individual has to weigh for themselves. And I sometimes object as much about a physician that is going to impose that kind of care on somebody who does not want it, as I object to the attitude of someone who would seek to prevent that being given to an individual. God gave us choice, and I think we honor and respect people when we allow them to make their own choices about what palliative care they would like to receive.
Yeah, I agree. At least the way it's actioned at Loma Linda, I think patients are very much given choice, and the whole idea of hospice, of course, is that they should die with dignity in their home and according to the circumstances that they would wish. But,
yes, I'd like to echo what Dr. Lanles was saying. When I, as a chaplain, come to pray with a patient, that is expected. They expect me to do that. But when a physician comes and prays with the patient, it instills in the patient this feeling that this physician is really connected with God. He not only depends on his or her abilities, but also on the power of God. Yes, it is also very familiar to see that many physicians are not comfortable. Some physicians have related to me that their discomfort comes because they don't know how the patient is going to react. The patient may be looking at them and saying, "You don't know what you're doing, that you're asking God for help?" So there is a discomfort there. But I have seen so many physicians that pray with patients, and it's so helpful. It does more work than me praying for patients. On the palliative aspect, and I will be talking about that in my last plenary and my wife and I on our last workshop, that is very important, how to help them go through that when there is no cure. And I remember when I came to visit a patient one time, and she was a cancer patient, and I asked her, if you had to live your life all over again, what would you do? Of course, for us chaplains, we have the time to ask that. Physicians don't have that much time. She looked at me and she said, "I will have cancer all over again." And then I said, tell me a little bit more about that. She said, "Well, we're all going to die at one point. With cancer, I had the opportunity to prepare. I had the opportunity to say my goodbyes. I had my opportunity to look at the whole process and prepare myself for that moment."
Okay. All right, thank you. Well, we've had a wide-ranging discussion. I don't know, this room is quite warm, isn't it? Are there questions that you would like to propose to the panel? There's a microphone here. There's another one over here. So apparently that one, there's no microphone there, so there's just one by the looks. Maybe I needed the second one. So if anyone has a question, can you make your way across to the microphone? I think there was someone here. Sorry, that's a little trek, isn't it, across the hall. Just to go out the back door and around. So, well, one issue, and I couldn't ask it of this panel because none of them are Europeans, I don't think, but do you see cultural differences between the American way of doing things and our traditions in healthcare? Our church is an American-based church, and how you would have to adapt things to Europe. I'm not trying to preempt your question, but maybe some of you might have something to say about that. Go ahead.
Well, I had my training in Sweden, and we have lived in England for a long time, and that's where I practice medicine. I'm a pediatrician myself. And when I hear what you say about Adventist hospitals, I'm very happy for you to be able to pray with your patients and to be able to talk to them. In Europe, at least in England and in Sweden, we have always been told you can't kind of pray with your patients and impose your religious beliefs on anybody. Of course, you do not want to impose on anybody, but you would like to offer them what you think would be helpful. So I would be interested in other comments, and I think there are more European physicians that might have the same experience.
Yes, Dr. Handysides is kind of European, kind of like I'm kind of European. Well, there are different sensitivities to these things, aren't there? I come from New Zealand. I think, at least in public hospitals, it would be a very unusual thing to do this. In an Adventist hospital, such as the Sydney Adventist Hospital, that would be much more expected, perhaps. But
Yes, I'd like to address that question. It is not much difference. Even in Adventist hospital, we should not impose our beliefs on people. We should not even pray for people or with people that are not open to that. So it is very important as a caregiver to be able to read the person. Because the person also has rights. They have rights because if they believe in prayer, they would like someone to pray for them. Right. It will be difficult for a government to say no, even though the patient wants you to pray, you cannot pray for them because here no one prays for the patient. So it's not much difference. As a physician, you need to be able to see and what we call God speak, the language that person speaks. When the person have God speak saying, well, I wish somebody will pray for me. I believe in God. You look around, is there a Bible there in that room? You need to look at what the person's background is, not to pray for everyone, but to be able that you're not imposing something on the patient that is not welcome by the patient.
Okay, well, that's good to see a long line. That means we should keep our questions brief and the responses brief, perhaps, and let's get through as many questions as we can. Go ahead.
Well, there's not only doctors in hospitals, but also in private practice. And I can testify that in living in Switzerland and practicing in Switzerland as a general practitioner, I have many, many opportunities to reach to the spiritual side of the persons, and that it is greatly appreciated of my patients. I can really tell you it's exciting, this kind of work that we can do. What I wanted to ask is, one of the speakers said that it's nice to see young people here, and at the same time he said that we see many gray-haired people in the health work. And my question is, does the church administration see that there's a necessity to attract young people to health-related professions? I mean, in the churches, go to the young people, reach them and attract them to these professions, to accompany them during the process of gaining their education, and to help them get and keep the vision that we were talking about. What is the church administration doing in these lines? Thank you.
Okay.
I'm really pleased to answer that, because I think the church administration today is doing more than has ever been done in the whole history of the Seventh-day Adventist Church from its inception. As we look at the current formulation for plans of comprehensive health ministry, I have never, in my experience, seen an administration that is so positive for a health ministry to take root in the church. I think that we need to realize we have a new paradigm in the church at the present time.
And as far as young people, can maybe just add quickly to that. We've just come from a training session in New York where it is 1 year in mission. Young people from every division in the world. This is something that I have not yet seen in the time that I've been in the church, and I was born into this church. So you can do the math. Where we are seeing young people being encouraged to follow these things. It's not a perfect solution yet, but there is definite direction in encouraging young people and making it an attractive option for them, and to try and implement that within our churches throughout the world and put them right at the forefront. If you look at the people who are doing the communication, even here, in the General Conference, the communication department is filled with young people who are promoting this message. So we're grateful for that.
Okay, we have 6 minutes.
Okay, one brief comment. I'm working in Austria, or I'm living there, and my hospital director told me, you know what, I'm a Protestant, we're living in a Catholic country, and you don't do missionary work here in the hospital. So that's the official experience. In my private office, I prayed with the patient, and most of them, they are happy about that. But just to make it clear, we have a different background and we have a different situation. Cure and healing, what I missed a little bit is the question, or addressing the focus. We have also quotations that we should act as Jesus. I mean, you said that. And I understand also that there is healing included also in the physical way. Jesus wasn't a physician, even if we call him like that, but he was a healer. I mean, he had no medical background, anything like that. So it's a little bit different. And the question for me would be, well, what do we do with the quotations that address that we should also heal the physical part as a church community, as a physician? That's one thing. And the other thing, if we discuss drugs and treatments, we discuss it from the standpoint we have now. We have the literature that gives us some evidence, but to me what is missing, and I would like to see if there are any ideas about that, if we take the councils, then we should know, for example, how to use all the water treatments. I had to go to a Catholic institution to learn more about that. We need also a proof, evidence of what we are told in the scriptures of Ellen White, what is really evidence there, what we can use today, or what is just a good idea, and some people, as private persons, they do it, and as a physician, I don't know what to tell them. I don't know if I can make it clear.
Okay. Any comments? I think that I certainly would have no disagreement with your comments. They make a lot of sense. I don't know where anyone else would like to.
You know, sometimes it's when motherhood is presented, one wonders quite where we're going, because what you're saying just resonates with us, and I just don't know. I don't quite feel where the problems are, but maybe that's because we're not understanding each other.
It's interesting to hear your experience in Austria in the hospital. Places are different. And, yeah.
I think that maybe the one issue, because we've discussed this before, is that I don't believe that healing, the ability for me to say, be healed, is what Jesus necessarily intends to be a hallmark of his church. And the spirit of prophecy as well is very clear. The writings of Ellen White are very clear that in our health work, we're to do the things that are available, that are not in conflict with good practice, but we are not necessarily, and all of us in our medical career or health careers have experienced and seen real healing, which is independent of what we may think is our skill. So it's not something that is absent from the church. It is something which is not necessarily always featured in the forefront.
Okay, let's move ahead. This may have to be our last question, I'm afraid.
Krínska, Czech Republic. I live in an atheistic country, and there are some influence of Catholic Church which use the prayer as a last possibility for the illness. I was working in hospital the whole life. When I suggest I will be praying with you, the patient is in horror. This is so bad with me, only the prayer. And please, there was two wonderful ideas, that the humanity is over the religiosity, and that we need more faith to the cure and more scientific to the healing. This is my attitude from the church. So what I would like to express also, that it's very difficult to transfer the knowledges from United States, which are always connected with the possibility that we working with the religious people to my community, which is ascetic. We must be very, very careful to transfer in an appropriate way. Thank you.
I must respond to this. There is a sense here that I'm hearing that the Europeans are different from the Americans. Now, I was born in England. I trained at Edinburgh University. I did my initial training in the public hospitals in Great Britain. I have never been at an Adventist institution of learning. So I am as secular a person as any of you, trained. It is so simplistic to think that we just would take a patient and say, I'm going to pray for you. You know, that's like taking somebody who's just had a pre-anesthetic medication and is kind of gaga like this, and we're going to go in and say, I want to pray for you. That's not what we're talking about. We're talking, first of all, getting to know your patients. And Europeans, surely you get to know your patients. I would never say to my Jewish patients the name of Jesus. We have to be sensitive about that. So when we talk about praying, it has to be done in the context of sensitivity and understanding. You must take a spiritual history. Do you take a spiritual history? If you don't take a spiritual history, you don't know if the patient has a spiritual propensity. So you have to take a spiritual history. You say, do spiritual things mean anything to you? That's how you begin to find out who might be a candidate to pray with and who not to. And when to pray. You're not going to pray as they're on the operating room table and say to everybody, hold it up now. Anesthesiologists, hold it. Nurses, hold it there. We're going to pray. I mean, surely you don't think Americans behave like that. You know, that's not the way it's done, okay?
All right, just very brief.
Yes, I'll try to be very brief, but I want to stand up to make sure that I'm understood. We are taught in America that it's unethical to evangelize in a hospital. You don't come to a hospital to evangelize. People came there for healing, not to be evangelized. We don't evangelize in a hospital. That's not where we do. When we pray for people, I agree with you. We have to be very careful. When I go and visit patients, usually if I have my white coat that has a cross and it says chaplain, I cover that. And I said, I am here, not because I have any specific information. I'm here because you are in my list of patients to visit. I'm the chaplain. I remember coming to a patient, so that you see that we all are the same, coming to a patient that just opened his eyes after an open heart surgery. And I was new. And I looked at him and he looked at me and I said, I'm the chaplain. And he said, did I die? Am I in heaven or in hell? Yes, people react like that. So we have to be very careful when we talk to people. We have to get to know your patient and find out if that patient is open for you to an intervention of prayer. You have to be very careful. It's unethical, again, to pray for people that do not want you to do that.
Well, thank you very much for an exciting discussion, and I'm sure there'll be other questions. Maybe you can address the panel individually. Thank you.